Welcome to Clinical Capsules from TRC Healthcare, your trusted source for practical, evidence-based updates. On this episode, Assistant Editor and Clinical Pharmacist Gina Corley shares updated guideline recommendations about acute bacterial rhinosinusitis, including when to start antibiotics, which agents are first line, and what supportive care measures can make a difference, in an excerpt from our popular Pharmacy Essential Updates webinar series. This podcast offers continuing education credit for pharmacists and pharmacy technicians. Please log into your Pharmacist Letter or Pharmacy Technician's Letter account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Catch new episodes of Clinical Capsules every second and fourth Tuesday, bringing concise, actionable insights from TRC experts straight to your ears. Let's take a closer look.
Let's talk about recent updates to the acute bacterial rhinosinusitis guidelines for adults. Before we begin, I want to make a quick note that acute bacterial rhinosinusitis is often just referred to as sinusitis or acute sinusitis. So you'll hear me use these terms interchangeably throughout the presentation. And as our article says, you'll see more watchful waiting for adult patients with acute bacterial rhinosinusitis due to updated guidelines. So today, we'll find out when they are needed, what you can recommend first line, and which agents to avoid. And to help us start thinking about this, here's a patient case. Jen is a 43-year-old female patient who has symptoms of a cold, including facial pressure, fever of 102, runny nose, cough, and headache. When asked how long she's had symptoms for, she says about 10 days, and her symptoms haven't improved at all. After seeing her prescriber, she's diagnosed with sinusitis. Should an antibiotic be recommended in this situation? We'll go through some things to consider when helping decide if an antibiotic is needed, and then we'll come back and revisit this case. So let's start off with some background about acute sinusitis. Sinusitis is the inflammation of the tissues lining your sinuses, which are structures in your face that are normally filled with air. When these structures get infected with bacteria or viruses, or irritated with allergies, it causes them to get blocked up with fluid. This is what creates the facial pressure and pain that people often complain of, along with a stuffy nose and other symptoms. Many people think antibiotics are needed for sinusitis infections, but the reality is that less than 10% of cases are bacterial, and the rest are viral. Therefore, the majority of cases should not be treated immediately with antibiotics. Plus, a lot of sinusitis cases resolve on their own in about a week or so. So how do we know if a sinus infection is bacterial or viral? Like we mentioned, most sinusitis cases are viral, but if symptoms persist for 10 or more days without improvement, or if they start to worsen after initially improving, we can start to think about a bacterial cause. In the past, antibiotics were typically started ASAP for patients who presented with severe symptoms. This could include fever of 102 or greater, nasal discharge with pus or mucus, or facial pain for 3 to 4 days. But now, new guidelines recommend watchful waiting for 3 to 5 days without antibiotics in most healthy adults who have been diagnosed with acute sinusitis, regardless of symptom severity. However, these patients should continue to follow up with their provider, especially if their symptoms get worse after the watchful waiting period. So as you can imagine, some patients may be upset or even angry about not being prescribed an antibiotic. For these patients, we want to point out that while antibiotics can be beneficial in some cases, the benefits don't always outweigh the risks, and watchful waiting can help avoid some of the side effects or the other downsides if antibiotics aren't truly needed. Some of the risks with antibiotics can include drug interactions, along with developing antibiotic resistance. Plus, they can also lead to a Clostridium difficile or C. diff infection, which is a bacterial infection in the colon that can cause severe diarrhea and can even lead to life-threatening colon damage. So now let's highlight some supportive care measures we can try. We know that in viral cases, we want to treat the symptoms since antibiotics won't help. But patients can still use some of these supportive care measures during a bacterial infection as well if they want some added symptom relief. This can mean an NSAID like ibuprofen or something like acetaminophen for fever or headache. Or patients can try a nasal steroid like fluticasone or triamcinolone to help reduce swelling in the nasal passages. But keep in mind that nasal steroids don't have a lot of data behind them that shows they help with sinusitis. Plus, they can cause nasal itching and nosebleeds. Patients can also try nasal irrigations to rinse out their sinuses. This involves using a saline solution with a neti pot or a rinse bottle to flush out the nasal passages and reduce mucus and congestion. If patients try this, we want to make sure they use distilled, sterile, or some other type of filtered water and never just plain tap water, since tap water can contain traces of germs and pesticides. We also want to encourage drinking plenty of fluids, especially ones that contain electrolytes, so patients don't get dehydrated. If patients ask about using a decongestant, we can point them towards a nasal decongestant, such as oxymetazoline. It has more data for acute sinusitis than pseudoephedrine, but the evidence isn't strong for either option. If patients decide to try oxymetazoline, make sure they know to limit use to 3 days to avoid rebound congestion, which is where nasal congestion actually worsens after initially improving with the spray. So now let's talk about which antibiotics you can expect to see in patients who do need them. And as pharmacists and techs, we can help ensure the right antibiotic is used for the right amount of time. As first-line therapy, we can generally recommend amoxicillin or amoxicillin clavulanate. Both agents cover Streptococcus pneumoniae, which is the most common bacteria that causes sinusitis. Generally, amoxicillin will be given to patients with mild to moderate symptoms, whereas amoxicillin clavulanate will be reserved for patients with more severe symptoms or patients who are immunocompromised or have a chance of bacterial resistance, since it covers bacteria that may not be susceptible to amoxicillin alone. But keep in mind, amoxicillin clavulanate can cause more side effects, such as stomach upset or diarrhea. So we want to tell patients to take it with food to lessen these symptoms. But we can also tell patients to take plain amoxicillin with food as well. So if patients get prescribed amoxicillin or amoxicillin clavulanate, let's go over what doses you can expect to see. For amoxicillin, expect to see 500 milligrams every 8 hours or 875 milligrams every 12 hours, both for 5 to 7 days. And then patients who get prescribed amoxicillin clavulanate will have similar doses, since this med is dosed on the amoxicillin component, but each tablet will also contain 125 milligrams of clavulanate. So we can expect to see 500 milligrams per 125 milligrams every 8 hours, or 875 milligrams per 125 milligrams every 12 hours for 5 to 7 days in these patients. And then I also wanted to point out that in rare cases, you may see high-dose amoxicillin clavulanate XR prescribed, which is 2 grams per 125 milligrams by mouth twice per day. This is usually reserved for patients who are at risk for a penicillin-resistant infection, such as those who are over 65, have severe symptoms, or have recently been hospitalized. But keep in mind that amoxicillin may not be appropriate in some patients, such as those with a penicillin allergy. For patients with a non-severe reaction to penicillin, such as a non-itchy rash, we can suggest cefixime or cefpodoxime, both with or without clindamycin. In patients who have had a severe reaction to amoxicillin, such as hives or trouble breathing, we can suggest doxycycline, since we usually want to avoid both penicillins and cephalosporins in these patients. And then looking at some other meds that you might be wondering about, we want to save fluoroquinolones such as levofloxacin or moxifloxacin as a last resort due to FDA's black box warning of serious adverse events such as tendon rupture and peripheral neuropathy. And then we want to emphasize that trimethoprim sulfamethoxazole along with macrolides are usually not effective due to high rates of resistance. And then I know that I mentioned the duration of therapy was 5 to 7 days of antibiotics when it comes to amoxicillin or amoxicillin clavulanate. But we can also suggest this duration for any antibiotic therapy that patients get for acute sinusitis, since data shows similar success rates and less side effects compared to the previous duration of therapy, which was 10 days. And then we also want to advise patients to follow up with their prescriber if symptoms don't improve within 3 to 5 days after starting their antibiotic, since they may need to try something else to get rid of their symptoms. So now let's go back to our patient, Jen. Based upon what we know now, looking at her symptoms and how long she's felt sick, would we want to start an antibiotic for her? And the answer is no, we would not. Jen does meet the criteria for a severe infection due to her 102-degree fever. And we can likely expect a bacterial infection since she's had symptoms for 10 days. So now this is the time when we would want to start watchful waiting and hold off for another 3 to 5 days before prescribing antibiotics. Remember, current guidelines recommend watchful waiting regardless of symptom severity in most healthy adult patients. And then just a few practice pearls to go over. We want to check ERX notes for antibiotics just in case the prescriber advises it to be put on hold in case the patient starts feeling better. Be ready to fill the prescription if the patient gets worse or symptoms don't improve in the next couple days. And then we want to watch the name, strength, and SIGs of antibiotics closely. For instance, amoxicillin and amoxicillin clavulanate look and sound similar, and they can both be dosed in a couple different ways for sinusitis. We also want to double check that the prescribed quantity matches the day's supply, keeping in mind that the day's supply should usually be between 5 to 7 days. Lastly, we can use stickers or labels to reinforce proper use. For instance, we can add a Take With Foods sticker to an amoxicillin prescription bottle to remind patients they should eat before taking this med. And then to wrap up, I wanted to tell you about our resource titled Antibiotic Therapy: When Are Shorter Courses Better? This highlights the benefits of shorter durations of therapy, such as a minimized risk of antibiotic resistance, reduced adverse effects, and improved adherence. Plus, it also has a chart that lists common infections along with the most appropriate antibiotic therapy duration.
Thanks for listening. We hope today's episode gave you practical insights you can use right away. Now that you've listened, pharmacists and pharmacy technicians can receive CE credit. Just log into your Pharmacist Letter or Pharmacy Technician's Letter account and look for the title of this podcast in the list of available CE courses. We've linked the resources we mentioned and more on today's topic right in the show notes. Those links will take you straight to our websites where you'll find even more concise, evidence-based charts, articles, and tools. If you're not yet a subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. Listeners save 10% on a new or upgraded subscription. Just use code CC1026 at checkout. Have a question or a topic suggestion? Reach out using the Send Us a Text link in the show notes or email contact@trchealthcare.com. Your perspective matters. Share your thoughts anytime to help shape future episodes. Thanks for listening. Stay sharp, stay current, and join us next time on Clinical Capsules.